All right. Well, welcome everyone to Thriving in Life and at Work Through Menopause. We're so excited to have you here today. The purpose of this event is to discuss the bold and often overlooked topic of menopause at work. By addressing this important topic openly, we aim to support each other in navigating this phase of life and fostering an inclusive and understanding world of work. We are going to talk a little bit about what this community is all about. If this is your first global chapter gathering or culture first gathering, we will have a fireside chat with some featured speakers who I will introduce shortly. We'll have some time for a bit of a Q&A. So for this particular session, love to have you drop your questions in the chat. And then what will be really helpful is for folks to either give like a thumbs up or a plus reaction to a question that you would really like to have answered as well. That would be great. And then we'll be able to ask the speakers, and then we'll have some closing announcements. This is going to be a quick hour together. If we haven't met, my name is Jessie Jacob. I am the Senior Community Engagement Manager here at Culture Amp, supporting our Global Chapters program. I'm based in Kansas City, Missouri, so I saw a few folks in here as well, but I now run our global chapters. We have 100 global chapters, 150 plus volunteer chapter leads, 14,000 community members, and we hosted almost one event per day last year, which is so bananas. Really proud. So, okay, if you're like, what is this? Who is the Culture First community? We are a group of people around the world united in the shared belief that a better world of work is possible. And by golly, we are willing to do something about it. We have 5 core principles that hold us all together. This is the glue that keeps us together. It's the way that we ask you to show up today. So we ask that you foster belonging and acceptance and just let people feel seen, valued, and appreciated for just being them and being here today. The second principle is being willing to reflect and grow. If we're on this mission to transform the future of work, that goes back to our organizations doing the work, but that ultimately starts with us being the change we want to see in the world. The third is to have the courage to be vulnerable. So, how do we create psychological safety and trust with one another? We are willing to be more of our real and authentic selves with one another on this mission, and it gives other people permission to do the same. The fourth one's putting learning into action. We hope that this conversation isn't just in one ear and out the other. We hope that you're inspired to take action in your personal life or your professional life, and you'll leave with some very actionable things. And the last core principle is connection inside, business outside. It's a fancy way of saying that in the context of this gathering, you're here to connect with us on the inside as human beings. And if that leads to folks doing business outside the conversation, that's awesome. We want that to happen. But hardcore sales and networking and all that stuff is not the primary purpose of our gathering. All right. So speaking of that last principle, have the courage to be vulnerable. This event is a bold move into an often under-discussed topic, and we understand that it may make some people here uncomfortable. And as we navigate this conversation, we may not get everything right, including language. We're going to talk about that. But we are committed to creating an inclusive environment. So we do welcome your feedback, whether you want to send me a DM directly or however you would like to share feedback. We are open to that. So please let us know if and how we can improve. All right. Lastly, I'm going to introduce the speakers and then hand it over to Sonja. But the first speaker, Sonja Montague MacKay, she's the founder of the More Human Company. She's also the Edinburgh chapter lead. So this is a co-hosted event between the Edinburgh chapter and the global chapter. Have known Sonja since the very early days of this community, and it's been a treat to not only collaborate and learn from her, and I'm always learning from her, but I'm honored to call her a friend. So thank you, Sonja. Here with Catherine Smith, the women's health specialist at the Coil Clinic. Sonja will do a more thoughtful introduction of Catherine, and Tall Tyson, international employment lawyer, and Littler employment lawyers. Super grateful to have you incredible women here today. So thank you. And I'm going to just hand it off to you, Sonja.
Thank you, Jessie. Are you going to do the technical stuff where you're going to pin
Got it.
Kat and I to start with? That would be awesome. It's so nice to actually have someone who can help with the technical background stuff. So I'm going to change that. So I'm in speaker view. Welcome everybody. I'm super excited to welcome you to this event alongside Jessie, which I'm hosting with actually my doctor. So Dr. Catherine Smith, she's a Scottish GP for many decades, and she's a menopause specialist and founder of the Coil Clinic. And Tyson, Tal Tyson, as Jessie mentioned, so littler law is quite hard to say, specializes in UK law. So the format for this is it's going to be like fireside chat. So I'm going to kind of like interview Catherine first, although I can't actually see her. Jessie, could you maybe put Catherine and I side by side, because I can only see myself. There she is. Yay, that's much better. Now I can see her. So I just want to run through very quickly some stats and facts around menopause. And the reason I really wanted to host this event is because I am a menopausal woman, and I went through real difficulty trying to get the right support. There's 47 million women around the world globally at the moment experiencing menopause. A 2024 BBC survey found that 23% of people considered resigning because of their menopausal symptoms. Yeah, 47 million, right? It's huge. Women lose about close to $2 billion in revenue because of their experience of either having to leave work or take time off work because of menopausal symptoms. The average age of menopause is 51. Perimenopause can start in your 40s and your 50s, and it's a real squiggly line to get there. And there's over 50 symptoms associated with menopause, right? From the well-known hot flushes and night sweats to anxiety, depression, itchy skin, dry eyes, short-term memory loss, palpitations, joint and muscle pain, of which I've experienced all of them apart from the dry eyes. So here we want to talk about how do we move to thriving. So Catherine is my rock star GP. Like, I love her. She's amazing, and I'm delighted to share her with you today. She is based in Edinburgh, so anyone who lives close to the West End can access her. But we're just going to do a kind of chat. So, Catherine, welcome.
Thank you, Sonja.
So happy you're here.
If I lose my train of thought, hopefully you realise that's just because I'm also perimenopausal, so that may well happen. So yes,
that's completely okay.
Bear with me.
So like we've got lots of stuff we want to cover, but I'd love to, we don't know where people are sitting on their menopause journey that are part of this conversation. So can you maybe just start by explaining the difference between like early menopause versus perimenopause versus menopause?
Yeah, I can try. So the average age of menopause for women, certainly in the UK, is around about 51, 52. But we know that menopause, which is the time at which your periods stop, can start at 48 upwards. Perimenopause, which is the transition towards menopause, can start anything from 10 years or so before menopause. So that could even be into your mid or even your late 30s that you start to have perimenopausal symptoms. Then menopause is when your periods stop, and postmenopause is when you've had no periods for 12 months. So you have to have been 1 year without any periods to be classed as being postmenopausal. The perimenopause is the transitional time where your hormones are very, very fluctuant. So your hormones are going up and down like this. You may have spells where your hormones normalize and you go back to having a nice regular menstrual cycle, and then they can be all over the place again. So it's a really tricky time in a woman's life. And as you've already said, it occurs often at a time when women are at the peak of their professional careers. They're often challenges with regards to parents getting older, more frail, lots of kind of stress from that end. And for some women or people who are having menopause, if they've got children or a family life, there's often lots of activity going around there, which is one of the challenges in determining whether the symptoms you're having are perimenopausal or are they due to other stresses. Is that anxiety you're feeling because work is difficult and you're not having enough time for yourself to exercise? Or is it all being driven by these hormonal fluctuations? So perimenopause, you may find that you are sometimes ovulating, you're sometimes not ovulating. Your periods can become heavier, they can become lighter, your libido can be really affected, your sleep is often interrupted, which is where it comes in with the symptoms of depression, because you often are not sleeping well, which may be due to night sweats and hot flushes inhibiting your sleep. You often start to have early morning wakening. And again, if you're not sleeping properly, then that has a knock-on impact on how you feel during the day, doesn't it? Your energy is often decreased, your concentration's not as good, you're more irritable because you're not sleeping well at night. And that all happens around the perimenopause and also postmenopausally. So the whole, from this time when your periods stop, that can last up to 12 to 15 years for some women, can have ongoing menopausal symptoms. So it really is a big wad of a woman's life that they can have menopausal symptoms. If you think, not 100 years ago, we probably died in our mid-40s, but now we're all living hopefully into our 80s or 90s. So it's trying to live well with menopause. You want to have the best life you can for as long as you possibly can, and have the least symptoms possible. That's not to say some women have no symptoms. Not everybody has debilitating perimenopause, menopause, postmenopause. Some women fly through it. A good predictor of the age of menopause is your mother's age of menopause is quite a good indicator. But I don't know if anybody else had this. Quite often when you ask your mum, how was menopause? Oh, all this menopause chat, that was never a thing in my day. I never had menopause. It really wasn't an issue.
I also think they don't know, right? It's like when I ask my mum, when I now reflect on her mental health, actually, I think she was experiencing menopause and she was completely misdiagnosed. And I think that happened to a lot of people who were in previous generations. So, I mean, I think this is where it gets really confusing for a woman, right? So I was perimenopausal, didn't know it. It was a friend who said to me, you're probably perimenopausal. And I'd never heard of that word before. I'd only ever heard of menopause. It was completely downplayed. And we're not even talking about, medically induced menopause, because that's probably another conversation. But I think it's very clear that it needs an open conversation and understanding. A lot of friends I speak to, especially down south in England, when I tell them the conversations we have, they don't get the same conversations with their own GPs. So given that there's over 50 symptoms, we don't always make the correlation. We don't always connect it to menopause, right? It's like, oh, I've got headaches, I've got poor sleep. We kind of rationalize it away. What advice would you give to anyone experiencing menopause to prepare for speaking to their GP so that they're heard, right? What's the best way that everyone on this call, or anyone who's watching it, can actually be as prepared as they can be to get a positive hearing, that they're not just having some other, mental or physical health condition?
Well, so I suppose one of the first things is that we all know our bodies better than anybody else. Okay, so if you think you might be perimenopausal and you're having those symptoms, then you know yourself, and that's a valid reason to seek help and to advocate for yourself. It can be really useful. There's lots of online menopause checkers, or apps that you can use. So that can be quite useful to just have a bit of documented evidence, I suppose, to present to your physician or your GP or whoever it is you're seeing, your women's health specialist, about, I've gone through this. These are all the different symptoms that I've got. I'm confident that I'm perimenopausal. I think the other thing to say is maybe speak to family members, because you may find that your spouse or your partner or your children are like, oh, you are a total nightmare, there's definitely something wrong with you. So that can be quite good evidence to take as well. If it was me, I would also, when I was phoning to book that initial appointment, which can be quite nerve-wracking, can't it? You've taken a lot of time probably to psych yourself up to make that phone call, to get interrogated, certainly in the UK, by the receptionist about why you need the doctor's time. So I think it's important at that stage to just ask, Is there somebody in the practice who specializes in women's health? Is there somebody there who's interested in menopause who I could speak to? Because not every practice, but quite often practices will have a doctor there who has more of an interest in it than somebody else. So don't feel bad if you normally go and see the old male partner who's really, really nice, but you think he just simply will not understand your menopause symptoms. He's not going to be upset that you've gone to see another doctor in the practice. In fact, he'll probably be very, very relieved that you've not started talking to him about your dry vagina and your decreased libido. So do just select who you want, who's going to be most appropriate for you to be seen.
And that's
If
how
at the
I found
point,
you. That was
yeah,
actually how I found you. So it's like I phoned up because I'd never been to that, because I'd moved to Edinburgh, I didn't have a practice. And I did get interrogated by the receptionist. And I said, look, can I please speak to someone who's sympathetic to menopause?
Yeah.
And they said, oh, let me think about that for a minute. And then I got referred to you. Otherwise, this could have been a very, very different conversation, right? And I think that's so important to advocate for yourself at that early stage.
Yeah.
You were going to say
I suppose I was just going to say, if you go and have that initial consultation and you don't find it helpful, try not to be put off. Ask to see somebody else. It's perfectly within your rights to ask to be referred to a specialist clinic if really there's nobody in that practice who has the right skill set, or you feel you've not been listened to. Don't be afraid to say, actually, I've not found this very helpful. Is there a local menopause specialist clinic? Is there somebody else that you can refer me on to have more of a discussion? So don't be afraid to see somebody else or ask to be referred somewhere else.
And I think that's really important, right? It's like knowing your rights as a patient, that you can actually ask for that. I feel that especially, different generations are more, they feel that the GPs are really overwhelmed right now, right? And they can't keep up to date with everything. But there's also like, oh, I can't challenge my doctor.
Yeah.
Whereas we have to put ourselves first, right? I think they're all really valuable points, and really worth everyone taking away, because we're not always heard, right? Let's talk about HRT. So when I first started getting symptoms way back in 2019, I was actually very anti-HRT, which will surprise everyone now because I'm such an advocate. But I just felt it wasn't natural. Like I had this in my head, I work in well-being, it's not natural. And I was doing like the sage and the black cohosh and the dim and all the supplements. And they did certainly help for a while. And I'm really grateful that I educated myself, right? So can you please firstly explain what HRT is, what hormone replacement therapy is, and why it's actually beneficial for anyone experiencing menopause to consider as an option?
Yeah. So HRT stands for hormone replacement therapy. So the hormones that you are lacking or that are decreased during menopause or perimenopause are estrogen. That's the predominant one. And it's the estrogen receptors that are everywhere in the body that, when we're not getting enough estrogen, causes us to have lots of those symptoms. For anybody who still has a uterus, you also, as part of your hormone replacement therapy, it's essential that you have progesterone, because if you have estrogen on its own, what happens is you get abnormal thickening of the lining of the uterus, which can lead to cancer of the uterus, endometrial cancer. So super, super important that if you have a womb, you have estrogen in combination with progesterone. Now, there's lots and lots and lots of different types of HRT. The one that's thought to be the safest is what's called transdermal hormone replacement therapy. And when we talk about transdermal, we're talking about patches, we're talking about gels, we're talking about sprays. And there's, yep, there we are. That's a spray. That's Lenzetto spray. Yep. And then I think you've got some different gels there as well, haven't you?
Yeah, we'll come on to that. And then that's the progesterone. So that's the progestin.
So patches come in combination patches, which is a patch that contains estrogen alongside your progesterone. And there's a once a week patch or there's a twice a week patch. Alternatively, and I quite like this, I'm a bit of a fan of this, is you can use your estrogen separate from your progesterone. So you can use an estrogen patch, an estrogen gel, an estrogen spray, alongside a progesterone, which could be something like a Mirena intrauterine device that sits within the uterus and continuously releases a low dose of progesterone protecting your uterus. Or it can be used in a progesterone tablet. The safest of those is something called a micronized progesterone, which in the UK has a brand name of Utrogestin. And we know that that's the safest type of progesterone to use. It's what's called a body identical progesterone. It's actually made from yam. It's plant derived, but it's most similar to your body's natural progesterone, which is why it's the safest in terms of breast cancer risk and thromboembolic, so blood clot risk. You can also get tablet forms of HRT. So HRT that comes in a combination with estrogen and progesterone. There are some newer versions which contain this modern micronized progesterone, which is the body identical progesterone alongside the estrogen. So most people, if you're taking HRT at the moment, you are likely to be, certainly the estrogen component is body identical, so it's natural estrogen. So anybody really prescribed HRT just at the moment should be on a natural estrogen. And then it's the progesterone that's more variable in terms of how you use it. You have sequential or you have continuous HRT. So if when you start your HRT, you're still menstruating, so you're still having periods, you would traditionally be started on what's called a cyclical or sequential HRT. So you're going to have progesterone alongside estrogen for 2 out of 4 weeks of every month, and then you will continue to have a bleed. If you have been without periods for 12 months, so you're postmenopausal, when you are started on HRT, you're started on a continuous regimen. So you will be having estrogen and progesterone every single day throughout the month, infinitum. And that's considered to be the safest form of delivery of HRT. Progesterone can sometimes cause side effects. That's often the hormone that women don't love taking. It can cause you to have some irregular bleeding. It can cause you to have some of the progesterone side effects of skin changes like acne, bloating, breast tenderness, headaches. So it's worth playing around. It's a bit like if any of you used the contraceptive pill when you were a teenager or in your 20s, it can sometimes take a little while to find the regimen that suits you. So again, don't be scared to go back. Just don't take the first standard option that you've been given. You may find that you try it for 3-6 months, you're like, oh, actually that gel's really fiddly, it takes ages to dry, I don't really feel it's absorbing properly, or I love swimming and I'm not, not enjoying the patches, everybody can see them, feel a bit self-conscious. So do make sure that you go back and you have that dialogue about looking at alternative options.
Yeah, and I think that's really important, right? So it's like, because I started on patches, now I'm on a spray that works better for me.
Yeah.
We could talk
Sorry.
about.
Oh, I should just say it's not contraceptive. So if you are on HRT, you do need contraception. And I saw a little box flip up. Can you just stay on the contraceptive pill? Absolutely. Yes, you can. If you're low risk, you can continue that all the way to the age of 50 if it's the combined oral contraceptive pill.
So Jack, I spray on my arm. So you spray in your forearms is where you use the Lenzetto.
Yeah.
2 questions just on HRT, and then we'll talk about other mechanisms. So let's go with, what's the difference between body identical and bioidentical, because this was a rabbit hole I went down.
Yeah. So body identical is what is prescribed by a doctor. So that is medication that has gone through all the correct procedures. It's a assigned dose. It's been, what's the word I'm looking for? I wrote it down because I knew I would forget the word I was looking for. Regulated, licensed. Okay. Whereas bioidentical. So body identical is what we would prescribe.
Yeah,
that's the safe one.
This is body
Yes.
identical.
Bioidentical is the ones that people will say have matched to your hormones and what you require. They're made in labs that are not licensed, they're not regulated. We really don't know what you're getting. It's difficult to ascertain as to whether or not, say, the progesterone that you're rubbing onto your arm that they say is safe is actually adequately protecting your uterus. So certainly within the UK, no registered doctor would be prescribing bioidentical because it's not regulated and we don't know its efficacy, if that makes sense.
Yeah, no, totally. I just think it's important to raise that because, you know, you do see ads for stuff like bioidentical and you're like, oh, that sounds really good. That sounds like it's going to be good for me. But actually, the HRT that we get prescribed today is not the stuff that was prescribed in the 60s and 70s, which came from a very different source.
Yeah, exactly.
So got a few more rapid fires with Catherine. Jessie, I'll get there. So does skin color impact the absorption of your HRT?
So that's really interesting, Sonja, because we discussed this, didn't we, last week? And I work in a predominantly white practice, so I really don't have many ethnic groups. So I looked it up and I could find very little research. I certainly couldn't find anything that said HRT is affected by skin color. I couldn't find any real good evidence that many studies had been done on different ethnic groups either. And certainly what I read suggested that menopause is probably underdiagnosed in other ethnic groups, that white women are very good at promoting themselves or better at getting access to HRT, other ethnic groups less so.
No, I think it's just, I did want to raise it because I think it's an important thing that we, you know, we all need to advocate for more research in this area, right? So that we're bringing everyone who's experiencing menopause along and no one behind. But conscious as to white women talking about menopause, I was like, we're not the only ones experiencing this, right? There's so many other people. So we're going to keep our answers slightly shorter so that we can cover these questions and then I can move on to Tal. No, you're awesome. I love you. It's just like I should have booked a 2-hour session. Vaginal estrogen, right? We don't often talk about it. Women do experience vaginal dryness. It can be really embarrassing for people. It's got the terrible name of vaginal atrophy, which made me feel about 110, right? I was like, oh my God, just put me on the shelf. Why don't you, right?
Yeah.
What are the options for women who do experience vaginal
vaginal dryness. Yeah. So vaginal dryness is really big, and you may find that even if you see a good physician that they don't actually ask you about it. So do mention it if you're having symptoms. So common symptoms are things like if you've got a prolapse, you might find the symptoms of your pelvic floor prolapse are worse. You may start to get increased frequency of urinary tract infections. You may find that that cycle ride that you did 2 weeks ago is suddenly just feeling a bit uncomfortable, and you're just kind of aware of your vulva in a way that you wouldn't previously have been aware of. So there's very few women who can't use vaginal estrogen. So definitely use vaginal estrogen, which in the UK you can actually just get from a pharmacy. There's lots of different types. There's a vaginal ring that stays in your vagina for 3 months. There's vaginal pessaries. There's vaginal cream. So again, it's about trial and error. So try one. If it doesn't work for you, you don't like it, try another. Sometimes you need to use 2 different types, so you might need to use a ring alongside a vaginal cream just to really re-estrogenize the area. There are some newer medications out there. There's a tablet that can increase the amount of lubrication in the vagina as well. Get on the vaginal moisturizers. There's lots and lots of good brands out there. Replens, yes. Use lots of vaginal moisturizer. Coconut oil, unless you're allergic to it, it's also really helpful. Basically, the whole premise is that you're just trying to really moisturize. If you're showering, avoid using shower gel, avoid using feminine hygiene products. Use, a simple moisturizer as a soap substitute when you're washing yourself, and don't be embarrassed about it. It's really, really common. Loads of women have it, and it may be the only symptom you have of menopause is just terrible vaginal dryness. Again, it really affects your libido. If you're going to be uncomfortable when you're having sex, puts you off having sex. So make sure you just go for it with the vaginal moisturizer. A whole year of vaginal estrogen is the equivalent to 1 dose of HRT. So you really can get away with using a lot and it not having any adverse effects.
Right, I've got 3 minutes to ask you a lot of questions on stuff. So we have to talk about testosterone, which has been a absolutely game changer for me. Now in the UK, it's only prescribed if you say you have a low libido, but personally, I've seen a massive change in my mood, my anxiety, my muscle pain has almost disappeared. I don't feel as if I'm walking on glass anymore. When should testosterone be added to the HRT mix? And a really short answer.
Okay, so you already have to have been on HRT. So your other menopause symptoms have to have been appropriately managed, because otherwise the testosterone is not going to be effective. And then again, you need to be seeing somebody who's happy to prescribe testosterone, because you are prescribing it off license, which means that all the products that are available, certainly in the UK, are really for men rather than for women. So the dosing can be quite tricky. It's important, if you are starting testosterone, that you are appropriately monitored. So you need to have your testosterone level checked at the start, and then at 6 weeks, and then depending on how well the balance is, maybe even more often. But definitely it can work really well, and not just Sonja, but I've had other patients who haven't really had libido issues, or that's just been one issue, who found it really helpful for their cognitive function and their muscle strength and just general well-being. So don't be scared to ask for it. The worst that can happen is that they'll say no, and then again you can just ask to be referred to somebody who would be happy to consider prescribing it.
I think it's so important. I mean, I'm still struggling to get my levels right, as you know. It's like it's up, it's down. The delivery mechanisms are really challenging. Like you get little packs like this and you're meant to take an 8. How are you going to get an 8th out of that, right? Absolutely insane. So 2 quick questions. Is it ever too early to start on HRT?
So anybody who's under the age of 45 who's having menopausal symptoms needs to have baseline bloods done. Okay, so you need to make sure that there's not any other reason for why you're having symptoms. So that's making sure you've not got an underactive thyroid gland, that you're not anemic, that there's not anything else going on. Assuming that's all normal and there's not any concerns that there's anything else going on, then no, there's no reason why you shouldn't be able to have a trial of hormone replacement therapy. But you may find that other options, like the combined oral contraceptive pill, if you're still not wanting to have babies, might be a better option for you if you're in your kind of mid to late 30s compared to somebody who you're looking at prescribing in their early to mid 40s.
And then is it too late to start on HRT?
Well, no, this is funny, isn't it? Because I told you the other day that I actually started somebody at the age of 80 on HRT. I don't think anybody else in the practice would have done that, but anyway, I did. So no, the benefits probably aren't there in the same way that they are in women under the age of 60. So we know that if you start HRT within 5 years of menopause or under the age of 60, that there's lots of additional benefits like osteoporosis prevention, cardiovascular benefits. And we know that if you start HRT over the age of 60, those are no longer, you don't get those benefits. But there used to be concerns that starting HRT over the age of 60 would cause you to have a heart attack and destabilize any plaques that had been formed. But all the evidence says that that's not the case. You just won't get the same benefits. But if you're having menopausal symptoms, you've got terrible vaginal dryness, you just feel rubbish and you want to give it a go, you feel like you've maybe missed the boat, missed out on something, and you want to see what all the fuss was about, there's no reason why you can't try it if everything else is fine, normal blood pressure, etc.
Yeah, I mean, it's like I got my brain back, right? I was like, oh, hello, where have you been for the last like 4 years, right? Very quickly, because I know we have focused a lot on HRT. If someone either can't take HRT or they don't want to, what are other options for ways to support themselves through menopause? And then we'll move to
Okay, so there are lots and lots of options. So we know that having a healthy diet, we know that not drinking alcohol or reducing your alcohol. We know that not drinking too much caffeine, taking regular exercise, we know that all of those things, those lifestyle changes, make a massive difference to improving how you feel during menopause. There are alternative therapies that you can try, things like magnesium supplements. Some people really benefit from those. That's Epsom salts in baths, it's gels, it's sprays, normally best absorbed through the skin. You can also try things like Sonja mentioned, black cohosh. There's some issues around liver toxicity with that. So evening primrose oil, sage leaves, some people find benefit from that. Otherwise, a really useful group of drugs is something called SSRIs, which if you're in America, you probably would have heard of Prozac. I think pretty sure I've seen adverts for that when I've been in the States. So that's a class of drugs that works through the thermoregulation center in the brain and can really help, particularly with hot flushes and night sweats. And it also can have some benefits in terms of anxiety and mood, because we also prescribe it for depression and anxiety. But interestingly, you need to be on quite a low dose for that to be effective. If you go up to too high a dose, actually one of the side effects of it can be hot flushes and night sweats. So it's about getting the balance right. There's other classes of drugs, the gabapentinoids can be helpful, but they are very potentially addictive and they've got a bit of a high street value, so they're prescribed less commonly, can have quite a few side effects. Another antidepressant, an SNRI called venlafaxine, can be helpful. And there's a new drug on the scene, which is a neurokinin inhibitor, which there's some good evidence for its use, particularly around hot flushes and night sweats in women who've had a history of breast cancer and aren't getting their symptoms controlled by other methods. Also, cognitive behavior therapy is in our new NICE guidelines. That could be really good. And there's this really good book. I don't know if anybody can see that. That's quite a good book, Managing Hot Flushes and Night Sweats, which is a kind of self-help CBT book, which can be really helpful too.
Thank you. Amazing. So I guess very, very quick recap would be it's all when you go to speak to your doctor, just make sure that you're tracking all of your symptoms, even if you don't think they're related, because the more that you track them, the more you're likely to make the connections between everything. If your GP is not as much of a rock star as you are, then it's okay to ask to speak to someone else in the practice. HRT is one option that people can go down to actually explore it. I've personally found massive benefit from it, but also there's lots of other ways to support yourself as you navigate this. And it's never too early or too late to have the conversation with your GP, basically, about menopause, are kind of my key takeaways. And yeah, definitely talk about testosterone. Catherine, you are amazing. I'm sure we can do a round 2 of this because there's so many things that we didn't cover. But I'm also conscious that I want to chat to Tal about workplace areas. You're amazing. Thank you. You're the best. Tal. Hi, welcome.
Hi.
I know we were so much to talk about. Thank you. I'm sorry. It was just such a great conversation with Catherine. I'm looking forward to having the same one with you. So when we spoke before today's event, I personally have a real concern about menopause being another thing that anyone experiencing menopause is going to get hit over the head with, right? It's like another reason to not either hire them, to not promote them, to, you know, see them as a difficult person in the workplace. And that was something we had a great conversation about. But as someone who advises companies on employment law, there's just a few things that I'd love to explore a bit further with you. And firstly, like, have you seen an uptick in companies requesting assistance with menopause policies, given that the consciousness of menopause is definitely being raised these days, right?
I think we're on the cusp of it. I'm not seeing it as much as I would like. I have to say, I first spoke about menopause to in-house counsel, must have been about 5 years ago. And it was viewed as really taboo breaking to even use the words menopause and menstruation in a room full of 500 employment lawyers, in-house counsel. And we got through that. So I think we're just in a process of consciousness raising. And I told that audience, and I've been telling audiences subsequent of HR and in-house lawyers, that they need to be very comfortable using the words with the concepts, and they need to educate themselves. So I think that the awareness campaigns are fantastic. The guidance that the UK government is putting out is terrific, and I think it can be used in other countries as well. So there's a lot more resources out there. So I think that the knowledge issue is one thing. Employers are always scared of getting sued. And HR is always navigating very difficult, performance issues and sickness absence issues and disability. Those are some really thorny day-to-day issues, especially where it involves, mental health issues. So they're hesitant, I think, to add something that they feel would raise more problems. But the fact is, they've gotten their arms around, we have gotten our arms around things before. We've gotten our arms around it from a discrimination standpoint. But I think the focus really needs to be for most people on a more positive direction, not just equalities law, but employers need to think more widely about it being a health issue. So in the UK and in most countries, employers have health and safety obligations to look at their employees and do a risk assessment. So this is a beautiful thing to do a risk assessment about. It's crazy not to do it. It's impacting a lot of employees. And I think that once employers start thinking about it within their health and safety framework, we'll see a lot more policies coming online.
Do you think if say there's like a lot of HR practitioners who may be on this call or listening to it, where do you start? Where do you start by, having a dialogue around menopause? Where do you start around like trying to shape some form of policy? I mean, you said like health and safety assessments. Is there anything else that you would recommend as that starting point?
Well, I wouldn't just take something off the internet. I'd start first widely educating yourself to understand the terminology, the things that we're learning today from the medical standpoint. There's a lot to learn. So I'd start with that. And then second, I'd talk to your employees. You can start with an anonymous survey. There's some models for this on various websites. And I think you have to be thoughtful about the questions you're asking and what you're going to do with the information. For example, you could ask if certain things would help. Would they find that helpful? Would it be helpful to have a menopause champion in the workplace? And then once you have that kind of information, you can then sit down and think about what goes into your particular policy. So that's where I would start. The other thing is I'd look at your existing policies and see, how you can adjust them to be fair for people going through these symptoms. Do they jump right into a disciplinary policy for certain kinds of absences, or do you go straight to a PIP without thinking about maybe, what may be contributing to this individual's circumstances? So I would read through all the policies that could be relevant and think about maybe you could put in the word menopause in your anti-harassment policy and say, let's not, have jokes about this, that, and the other thing. It's not just a bit of banter to say, or this computer is downright menopausal. Let's not use those kinds of jokes.
Yeah, it's a normalizing of the language, right? And I think I shared with you, is like, I used to run a team of people of which I was in my 30s, and I for sure had women in their 40s and 50s. I had no idea that they were experiencing perimenopause, right? I just didn't know. And they never ever came to me to ask for support. So I think it's like, educating more broadly that this is something that everyone who has a uterus is going to experience, right? You're going to go through menopause, and we actually have to normalize that in the workplace to talk about it. What are your thoughts on companies paying for stuff like menopause health checks? Because it's really hard sometimes in different parts of the world. Obviously, Catherine and I are in the UK, but to even get in to see an NHS doctor can be really hard, and a lot of people are going private because of the wait times. Like, would you see that as an affirmative pathway forward? And is there any language that people would need to be careful with around, you know, not calling them women's menopause health
Yeah.
checks, right?
Well,
So
I think you're throwing me a softball question here because it's absolutely a wonderful benefit. It's a huge win for an employer who's done the survey to, in response to the survey questions, of which this could be one, say, you asked for it, we're giving it to you. I mean, we always want to feel that employees feel heard. And so I do think it's a win. After you and I spoke, I did some Googling on some private insurance companies, and they've got some really sophisticated, great things. Like there are landing pages now on a lot of those companies where they talk about this benefit that employers can pay for. It can last up to a year. So yeah, I think it's a win, that one.
And it's like, I guess it's like treating it with compassion and kindness, right? It takes a lot to talk about menopause, right? Because I mean, I struggled with it at the start, right? Because I was like, oh, I'm just aging myself, right? I'm outing myself as being a menopausal woman. Yay. And it was hard, but I was like, you know, we have to, you know, I feel that if we all come together and take a stand, it's going to be really important. Jessie, is there any questions in the chat that we can direct towards Tal?
While we're waiting for that, I do have one thing about,
yeah,
I think that we should all be speaking more about it and more comfortably about it. I have seen employers get into trouble where people will speak about, you know, their partner's menopause, and they assume that they're a menopause expert because of, you know, what they went through. We saw this with pregnancy as well. Just because you've seen one or gone through one doesn't mean that, you know, you're suddenly an expert. So I think it's really important that for workplaces to be very careful about telling, you know, managers or leaders to start talking about menopause ad hoc, because that too can be.
I think that's a really good point. And there's also the fact that we haven't talked about medical induced menopause because we obviously don't have time today, but that can happen when people are getting, you know, whether it's chemotherapy or other medical challenges which cause them to go into an earlier menopause. So it's not a one size fits all, right? It's like, how do we make it more inclusive for women
people
to get the support? Yeah, for people to get the support they need to. Is there any kind of top tips that you would want to share?
Well, just to finish off that one thought, if you're doing a policy, it's very easy to make it more inclusive by not using she. It could be, you know, employees or they is one tip. And then I think just raising awareness in a thoughtful way and not an ad hoc way, because it is new. And I think people need to tread into this with knowledge. And there's plenty of guidance out there.
It is new, right? And we're going to trip up. We're not going to always get the language correct. And the intent is to be as inclusive as possible. So can you just repeat that in terms of, if you're writing these policies around menopause, what's the best practice around languaging?
Well, I also think that it's helpful to have a transgender policy that explains the current definitions that the firm uses and why. Again, there's government guidance around current terminology. So you can look at all your policies from the same perspective, but in the menopause policy in particular, there's ways of writing it that talk about people who are undergoing menopause. And they, rather than just using the term women.
Yeah. I think that's so important to raise, and thank you for saying it so eloquently and beautifully and lawfully, because I do think it's a space we're all kind of leaning into more, and we all want to support each other as we move through it. I'm going to just turn it back to the questions in a second, but is there any kind of those, so I'll share that link that you shared with me, Tal, as well, around the legislation link, which we'll send to everyone. But any other top tips around, you know, starting to bring this menopause discussion to the workplace before we turn it to the audience questions?
You know, I think it shouldn't be individual employees' job to do this. I think that's asking a lot. It's hard, as you were describing, even to talk to the receptionist at the doctor's office. Bringing this up as an individual woman at the workplace, that's too much to ask. So I think this is the job of people like me, employment lawyers, external employment lawyers, in-house counsel, and HR to pick this up. So if you're listening, you know, we should be talking about it. We should be identifying all of the resources and considering, you know, how to sell this to decision makers and explaining why it's so important.
Yeah, no, beautiful. And just on that point, it's like the first time I phoned the practice, when I phoned my GP's practice, it was during COVID, right? So it was lockdown, and the reception said, "Is this urgent?" And I was like, well, not really, like I'm not dying, right? So I was like, no, it's okay, right? Very typically Scottish. I was like, no, it's all right, it's fine. But then my symptoms got so bad, I was like, look, I actually am losing my mind here. Like, you know, it really is important. So I called back and I was like, yes. But that just talks to that point, right? It's like, you know, we're raising the social consciousness, right? And that's what we're doing today. We're trying to be supportive of each other. So thank you.
Thank you
for those words of wisdom. Amazing. Jessie, I'm just trying to see here. What was the context of that first question? What can they actually do to offer support? I'm not quite clear on that one. One of the questions, this is for Catherine, does HRT increase risk for some cancers?
So the commonest one it increases the risk for is breast cancer. It increases your risk from 23 women per 1,000 of the population. It increases it, depending on which study, by about an additional 8 people. But to put it into perspective, having a high BMI, so being obese or overweight, increases your risk by more than using hormone replacement therapy. There's some thoughts that it can increase your risk of endometrial cancer as well, depending on what type of HRT you use. But breast cancer is the big one that it's associated with.
Amazing, thank you. And then Jessie, would you mind just popping up that slide that I had about the common sense support stuff? So this was something I've got a download I created in 2019. I actually got interviewed about menopause. And this is from 2019, right? So these are just some other common sense things to do about the workplace. So well-being programs, learning how to yourself use your breath to manage stress and menopause symptoms, access to confidential counselling services, open discussion around job design to support you during this period of time. Like there might be some slight changes that need to be made. Assurances on job safety and security and support for employee health and well-being. Like, you know, we're not all knowledge workers, right? Some of us are actually, like I used to work in a grocery store, right, all through university, and the uniforms were like polyester and you would just sweat like no one's business. So if you're in, if you have like factories or grocery stores, so appropriate uniforms are made of natural fibers, and just other things to think about, support to attend medical appointments, increase awareness, which Tal and I have talked about, removing the stigma, which is hopefully what we're doing today, and just regular breaks, access to bathroom facilities. So I just wanted to share that as this was 2019, right? And we're still talking about it, and a lot of these things have still not happened. Jessie, anything else before we move to wrapping up? Any other questions that I've missed because I haven't been on the chat?
No, this has been amazing. I mean, we're gonna skip this part. So I'm just gonna say other ways to stay connected. We'll have more global chapter events. There's all of our Culture First Global. If you missed that a few months ago, all that content's on demand. You can keep the conversation going in our digital Slack community. You can be registered on our newsletter, on our Culture Amp newsletter. And we can send this out afterwards, but want to make sure I have a few moments I'm going to remove all of you from Spotlight and would love if everyone would be willing to just like come give a little love for these speakers today, whether come off mute, giving a reaction, pop it in the chat. Thank you so much. This was incredibly powerful, and we definitely can keep the conversation going. Yeah, let's
In the
just
chat where you can get in touch with Catherine, and then I'm just gonna find Tal. If you want to follow up with any of them for conversations after this. But thank you everyone for coming
Good.
along.
Yeah, let's do a one-word checkout. So what's one word to describe whether it's how you're feeling or a word that's resonating for you? And just go ahead and drop that in the chat. Yeah, reassured, something validating, appreciative. Yay. Oh, so good. A lot of encouraged, a lot of enlightened. Amazing.
Yeah, we're not alone, right? It's like we are in this together and we can support each other as we navigate it because it's not linear.
Totally. We
I'm
will
happy
keep
to
this
share
number
Catherine.
going.
She's awesome. She gets embarrassed because I'm always saying how good she is, but she really is. And Tal, thank you for those words of wisdom. That was like phenomenal. So
Thank you
good.
so much.
So
So
awesome to have both of your perspectives. Was so valuable. So thank you. Thank you, Sonja, for facilitating. We'll have this recording out to you all afterwards. Feel free to share any feedback with us. Let's stay connected, and we'll keep the momentum going on this topic because it sounds like there's even more we could have discussed. We can go down the rabbit hole together.
no, and Jessie, on that, I would love to hear back from people. Like, what would you want to cover? Would you want us to run another session? Like, what would be supportive for you? Because a lot of this is just like my learnings and the feedback I get from people I speak to. It's like, it's like, hey, I wish I'd known this. My life would have been so much easier if I'd have known this like 4 years before, I melted into depression, anxiety, mood, basically losing my mind. So yeah, if we can support each other, that's a plan.
Yes.
Natural remedies, absolutely, Paula.
Oh yeah, that would be great. All right, everyone. Well, thank you for being here, and cheers to co-creating a better world of work. Just one bold topic at a time. We will see you next time.
Thank you, Jessie. Thank you,
Bye.
you're amazing. Thanks, everyone.